Thanks so much for having me, and I want to begin by thanking all of you. These are photographs that have been shared by families affected with congenital muscle disease for the care guidelines that are actually I'll talk about later, that are posted online. And I love these photos because they just show individuals that are affected with congenital muscle disease just living their lives. And I want to thank all of you for teaching me every day what true strength really is. So I'm going to try to be as comprehensive, but more importantly, comprehensible, in trying to address the big and really wide topic of the RYR-1-related conditions. And just to kind of give you a little bit of background, it was really the 1950s and 1960s when, based off of muscle biopsy appearance, we call histochemical, meaning the staining of proteins in the muscle, and ultrastructural appearance, meaning the electron microscopy appearance, that these conditions were recognized and then described based on their appearance. And so, as you see here, I'm not sure you can see my arrow. So central core disease was described in 1956 based off the appearance of decreased, we say oxidative staining. So an area where there's decreased stain in the center of the muscle fiber you see here, where there's really decreased what we call mitochondria. So that appearance was described way back in 1956. Multi-mini-core disease, also decreased staining, but not discrete kind of circular like the central core, but more of kind of a little bit of rubbing out of the oxidative staining, different areas of the muscle. Central nuclear myopathy was described in 1966, and Nemelin myopathy described in 1963. So we've known the appearance for quite some time. But it wasn't until 1993 when a group in Cork, County Cork, Ireland, had actually discovered that the gene, the RYR receptor 1 gene, the RYR1 gene, causes not only malignant hyperthermia, but also central core disease. In the subsequent 25 years, we've realized that RYR1 mutations are the most frequent genetic cause of congenital myopathies. So I'm not going to try to tackle this complicated figure or this topic because Dr. Dirksen will talk about this next, but just to suffice it to say that the RYR receptor type 1 is a skeletal muscle sarcoplasmic reticulum calcium release channel. And it's important to recognize it as a channel because some of the features that a lot of you experience are what we call symptoms of a channelopathy, and I'll go into that a little bit later, but the release of the calcium from the RYR1, the calcium release channel, basically by kind of a chain of events results in contraction. So you can see down here actin and myosin. When the calcium is released from the RYR1 receptor, it first binds to troponin C, and then with a chain of events to tropomyosin, ultimately allows the binding of myosin and actin, which really produces force in the muscle. So it's really intrinsically important for the production of force in the muscle. And this whole process is called excitation, contraction, coupling. And the RYR1 protein, as well as the dihydropyridine protein, are the two essential proteins, channels that work kind of as part of that production of force and contraction of the muscle. So mutations in the RYR1 gene can result in different muscle biopsy appearances. So as Dr. Wicklund pointed out, we can describe these by muscle biopsy appearance, or we can describe it as part of the RYR1-related conditions. But it's important that we actually discuss the different terminology used for the biopsy appearance because many of you have been told these terms during your diagnostic journey. So again, RYR1 can result in central core disease, multi-mini-core disease, central nuclear myopathy. Congenital fiber type disproportion, which I'll talk about, is really a pathologic descriptive term, not a diagnosis in itself. Core rod myopathy. And in general, the clinical course can be typically static or slowly progressive. But there are also exceptions, and I'll discuss those. I wanted to, at the onset, mention the important role that muscle imaging plays for us because the complexity of the RYR1 genetics, which I will not touch upon, but my colleagues will in great detail later, it really helps us so much to have the tool of muscle imaging, muscle ultrasound, muscle MRI, because it can help us in interpreting whether a particular RYR1 mutation is indeed causative. We use muscle ultrasound on all of our patients. We find it to be extremely patient-friendly. It's really painless. We can do it at bedside. And it can give us basically a magnified view of the muscle, more magnified than the muscle MRI, and can be sensitive in picking up certain patterns. So I mentioned this and stressed this at the onset because RYR1 has a very particular pattern. So you can see over here, I'm showing you a muscle ultrasound of the quadriceps, and the quadriceps are 4 muscles. RF stands for the rectus femoris, and I place that in red because the rectus femoris muscle tends to be relatively spared in RYR1-related myopathy. And especially when compared to the other surrounding muscles of the quadriceps, so the vastus lateralis, the vastus intermedius, and the vastus medius. Here is actually the echo from the bone. So when we see this pattern, relative sparing of the rectus femoris muscle, we can think about at the onset, even before we do genetic testing, that RYR1-related myopathy is a very high possibility. And so muscle ultrasound is exceedingly helpful from our perspective. Muscle MRI, for those who can lay still for the MRI scan, is also exceedingly helpful. It has a pattern, as I described with the muscle ultrasound, of that sparing, that general kind of relative sparing of the rectus femoris muscle. And there can also be some sparing of the gracilis muscle here, and some sparing of the adductor longus. And sometimes muscles that are spared that appear darker here, that appear darker, can also be a bit larger or hypertrophied. So as you can see, there's a really distinct pattern here in the MRI, and that also can be very helpful when you're going through that diagnostic odyssey. And here's the lower leg, and you can see that the tibialis anterior muscle, which is darker here, tends to be less affected, as well as the extensor digitorum longus and tibialis posterior and the gastrocnemius medialis. Now, not all centers can do muscle MRI, but if you can get a muscle MRI performed at your center, it's important to share that with those muscle specialists that may recognize the pattern. So we often will receive sent to us a muscle MRI to review, and it can be a very important part of the puzzle. And going into just the overview of the different muscle biopsy findings that can be seen secondary to RYR1 mutations. Core myopathies are named for the reduced oxidative staining in the central part of the muscle fiber, and they're well demarcated versus the multimini-cores, which are less well defined. And initially there was a clinical picture that was described in association with central core myopathy. It's become more complex over time, but what we can see is that in general, when there are autosomal dominant mutations, the presentation can be more mild when compared to the de novo dominant mutations, which again my colleagues will talk about in the genetic sessions. But de novo meaning not inherited mutation, so it happens spontaneously in the individual when basically a misspelling in the RYR1 gene which was not automatically corrected. So de novo dominant can be a little bit more severe. Some typical findings of hypotonia, low tone during infancy, congenital hip dislocation, and scoliosis are very common. Extraocular muscle involvement, meaning involvement of the muscles of the eyes that decrease your ability to look all the way to the right or the left or up or down, that's quite common, but is actually more mild in the patients with the dominant RYR1 mutations, as well as respiratory involvement and facial weakness and bulbar weakness, meaning difficulty swallowing, can be more mild in the central core subtype of RYR1-related myopathy. And most patients will achieve independent ambulation. Of course, there are exceptions. And the multimini-core myopathy can be caused by autosomal recessive mutations, so 2 mutations in the RYR gene. But it's also important to point out that this same exact muscle biopsy appearance can be seen in a different gene known as selenoprotein, or now called selenon, or SEPN1. So both RYR1 and SEPN1 can cause this multimini-core appearance. External ophthalmoplegia, meaning difficulty of full eye movements, is actually very common in RYR1-related multimini-core myopathy, as well as prominent central axial muscle, like neck flexion and proximal muscle weakness. And there are severe cases of antinatal onset, manifesting with decreased fetal movement, as well as arthrogryposis, meaning fixed contractures of the joints, notable at birth, and respiratory insufficiency, which can occur in the setting of 2 mutations, so recessive mutations in RYR1 with a muscle biopsy appearance of multimini-core. then in 2010, colleagues of ours in South Africa, Dr. Wilmhurst, had recognized, and his colleagues had recognized that there are patients that have prominent facial weakness, decreased extraocular muscle strength, so decreased eye movement, proximal muscle weakness, and very prominent symptoms really at birth, or congenital symptoms. And what was notable is these patients had on muscle biopsy central nuclei, so central nuclear myopathy, and they recognized with genetic testing these patients actually had mutations in the RYR1 gene. So they were describing a new clinical picture, a new clinical, we say phenotype, or clinical picture of RYR1-related myopathy with a muscle biopsy with central nuclei, decreased extraocular movements, and prominent facial weakness. Dr. Bonneman and colleagues described that also there is, at one end of the spectrum of the RYR1-related myopathies, a severe neonatal presentation which can occur, and it's complicated because it can occur in both recessive mutations in RYR1 or dominant mutations in RYR1. And so it's not really just one type of mutation, but the presentation can be very severe and prominent at birth. And so some patients have respiratory involvement necessitating full-time ventilation evident at time of birth. There's a pattern of myopathic face, or kind of weakness of the facial muscles. Poor feeding is not uncommon, at least initially, necessitating nasogastric tube feeding. Ophthalmoplegia, which again is that difficulty in full gaze, full eye movements. Low tone, and this is demonstrating down here some of the fixed contractures of the distal joints, arthrogryposis. This young girl here actually has a cleft palate, which also has been seen in some patients with the severe neonatal presentation of RYR1-related myopathy. What is notable is that the muscle biopsy has prominent cores, and so that is definitely in keeping with other RYR1-related myopathies. And these patients also had muscle ultrasound findings with relative sparing of the rectus femoris muscle, which was a very important diagnostic hint when muscle ultrasound was performed in these young children, even during the first few weeks of life. I just wanted to point out that congenital fiber type disproportion is really a muscle pathology descriptive term. Sometimes individuals are given this as a diagnosis, but it really is a description of the appearance of the muscle biopsy and is not specific to particular genetic conditions. So it can be seen very commonly in RYR1. We also see it in SEPN1-related myopathies. We see it in ACTA1-related myopathies. So multiple genetic congenital myopathies can have the same exact histologic or muscle biopsy appearance. And what I'm showing here is these dark fibers, the type 1 fibers, which are smaller or atrophied or hypotrophied, smaller fibers compared to the lighter fibers are type 2 fibers. So the slow twitch fibers here are smaller, the type 1 fibers, and type 2 fibers. A very profound pattern, but again, in itself does not point to RYR1-related myopathy. However, if you have muscle MRI appearance like this, where you see relative sparing, meaning less involvement of the rectus femoris muscle and the gracilis and the adductor longus, that gives you much more evidence towards an RYR1-related myopathy. So if you have this muscle biopsy pattern and this muscle MRI pattern, then you would be thinking this most likely is RYR1-related myopathy. There have been some patients described with what we call core rod-related myopathy, core rod myopathy secondary to RYR1 mutations. You see both cores as well as some rods, so kind of the increased staining here, kind of the reddish appearance staining on the trichome stain here, and the rod is seen on the electron microscopy. And here's a core on the electron microscopy ultrastructural findings. So again, it's a histologic appearance that can also be seen associated with RYR1. So you're kind of getting this picture of, a very wide spectrum of muscle biopsy appearance and a very wide spectrum of clinical presentations. Just to give you a brief overview, so we mentioned central core disease, multi-mini core disease, central nuclear myopathy, this is Nemelin myopathy, this is congenital fiber type disproportion. You see that RYR1 actually overlaps with all of these different congenital myopathy groups. And so that causes a little bit more complexity, but again, there are ways we can navigate through the diagnostic journey to help us recognize that indeed this is where we should be focusing our attention. I just want to also mention that there have been 2 papers that have described a more unusual presentation of RYR-1-related myopathy. It's a very late onset axial myopathy due to dominant mutations in RYR1. You have a 77-year-old male who had a 5 to 10-year history of difficulty basically standing up straight, so trunk extension. So he's leaning forward to balance himself. That's a very unusual presentation, and that was found to be secondary to an RYR1 mutation, which had never been described before, so it was clearly causative mutation. And the muscle biopsy shows here a multi-mini-core. And another paper of a gentleman in his 60s with progressive trunk extension weakness, similar to this gentleman, and also had a dominant mutation RYR1 and some oxidative kind of clearing here on muscle biopsy. So again, rare, but to be kept in mind as well as part of the wide spectrum. So here we are kind of trying to summarize that clinical spectrum, where we call phenotypic spectrum, quite wide from the more severe neonatal form of RYR1-related myopathy to a congenital form which has the restricted extraocular movements and hypotonia and scoliosis, to a congenital form with clear proximal weakness and then an adulthood clear limb girdle weakness, to this late onset axial myopathy, which is really just more of a trunk extension weakness. Again, I'm not going to go into the complexity of the RYR1 genetics because my colleagues Olivia Medney and Kim Ambergy will be talking about that shortly, and Angela Gruber. But just to mention that this is back in 2007. With the increased availability of these panels that are now available for testing, we call them next generation sequencing panel, there's been many more RYR1 variants found, and so we recognize now the clinical spectrum associated with the RYR1 mutations has been expanding and will likely continue to expand. And so initially, we knew that there were these hot spots on the gene, and there was this tendency of thinking that this C domain of the gene was more likely to be seen in patients with central core disease. But now things have become much more complex in the past 11 years, and my colleagues will mention that. And then I wanted to just touch on briefly, and this will be discussed by Dr. Sheila Riazi, there are also manifestations in RYR1-related myopathy of paroxysmal so-called episodes. And these really, I think, are really manifestations of what the RYR1 channel really is. And so channels can intermittently have paroxysmal manifestations. And so one of those paroxysmal events that can happen in the setting of particular individuals with particular mutations in RYR1 is malignant hyperthermia, and this susceptibility should be considered possible in all patients with mutations in RYR1. And so I think this is also something that we uniformly keep in front and center in our mind when we're working up patients for any form of myopathy, that RYR1 could be going on, that we always should keep in place what we call MH, or malignant hyperthermia precautions. And so the formal definition is that it's a pharmacogenetic, meaning a condition that you're predisposed to based on your genetic changes, disorder of skeletal muscle that presents as a hypermetabolic response to potent, volatile anesthetic gases, so certain anesthesia agents, as well as a muscle relaxant that's called a depolarizing muscle relaxant called succinylcholine. These are agents which are typically used to put someone to sleep for a surgery, and so it's important that MH precautions always be used, even when you don't have a genetic diagnosis yet. And also, this type of episode, paroxysmal episode, such as malignant hyperthermia, can also occur sometimes with stressors such as vigorous exercise or heat. So it's important to remember that paroxysmal episodes can occur in the setting of RYR1-related myopathies. I just also wanted to mention that there's a condition that had been termed years ago King-Denbrough syndrome, based off of the clinical presentation of ptosis, or droopy eyelids, and some facial characteristics of a prominent philtrum, which is the area right above your lip, low-set ears, short stature, and spinal rigidity and scoliosis. This condition has been now linked that it can occur secondary to RYR1 mutations, and so it's not known if all patients with the King-Denbrough syndrome with these symptoms have RYR1, but it has been associated. And a prominent feature of King-Denbrough is this tendency towards malignant hyperthermia. And then just to touch on one of these type of clinical presentations, that is, of this paroxysmal episodic presentation. Here's a family. They all have the same RYR1 mutation. The mother has recurrent rhabdomyolysis, very high CK. She developed limb girdle weakness in her 5th decade of life. The daughter has recurrent rhabdomyolysis, and the son has baseline high CK and muscle hypertrophy. And so you have basically a very varied manifestation. So he has no weakness and actually hypertrophy muscles, while his mother has developed weakness over time. And then all three have eyelid kind of droopiness of the eyelids we call ptosis. And then also there have been some reports of periodic paralysis or periodic episodes of weakness occurring in the setting of RYR-1-related myopathy. So again, possibilities of these paroxysmal type of episodes. And these happen in patients that were in the late teenage years to early 30s, where patients suddenly could not move for a few hours duration. And then actually often begun with some myalgia, muscle pain, and followed by severe weakness lasting hours. And these patients often also experience episodic cramps. Very importantly, I think, is focusing on optimizing care for everyone. And there is a couple resources which are actually on the Cure CMD webpage. So this one actually is fantastic because it's put together by families and congenital muscle experts. And so if you go onto the Cure CMD website and go through the clinical care guidelines, it's very readable. It's a wonderful resource. Here's a paper published by specialists in the field. It's probably helpful to share with your physician, but it's a little bit detailed and not as probably helpful to have in hand as this guide for families. And I would just say briefly, it's essential to focus on care while we are working towards treatments. It's important that everyone focuses on the care, because we've experienced at the NIH, and we enroll patients for a clinical trial, that we want to make sure everyone has the utmost standard of care. And we were shocked to realize that many patients came to us who didn't have the standard of care. I know I'm running out of time, but I don't want to miss the opportunity to mention we need to be proactive about respiratory care. It's the single most common cause of hospitalizations and severe complications in congenital muscle disease. And I know that patients are often told that, they have on the sleep study obstructive sleep apnea. That's an interpretation of a sleep study finding, but it's important that we recognize it is uniformly the situation that in congenital myopathy, there's a restrictive lung pattern, and it's secondary to what we call extrinsic causes of restrictive lung disease, because there's weakness of the intercostal muscles, there's weakness of the diaphragm, and there's decreased stretching or compliance of the chest wall. So this is important because everyone should be having then an assessment of their breathing, most importantly during sleep. So a sleep study or a polysomnogram is essential to have to assess for hypoventilation. And you need to measure carbon dioxide during that sleep study to assess for that. And then if you are diagnosed with hypoventilation, BiPAP, bi-level positive airway pressure, is essential to initiate. And I say to all my patients, BiPAP is your buddy. Because I say that is because if you're offered CPAP, CPAP begins with a C and buddy begins with a B. CPAP is not your buddy. BiPAP is your buddy. And why is that? BiPAP is a high pressure for inhalation, a low pressure for exhalation. It is hard to breathe out against pressure. What we need for our patients is BiPAP, a high pressure for inhalation, low pressure for exhalation. This is life-changing and life-saving. That's why I want to make sure everyone does not forget to pay attention, very good attention to the lungs. Finally, I call the Caucasus Machine the miracle worker. It has changed the entire congenital myopathy field. Before this came on the field, my patients would have 10 hospitalizations a year, possibly with chest infections. After this machine came on the field, no hospitalizations. So ask your doctor, your pulmonologist, with the Caucasus machine. It's very important to stimulate cough. It can be used daily for exercise as well. All right, so progressing towards clinical trials, which is happening, you'll hear about today. Most important thing I would say, number one, optimize clinical care. Number two, concentrate on natural history studies, and that as a field we are working on. So comprehensive natural history studies to gather data of how the condition is at baseline, and a patient registry. And I'll leave you with a quote here from one of a parent. We tend to assume that the medical staff will always know what is best. I think if we enter every situation realizing that each of us has useful knowledge and experiences with congenital myopathy, helps to remind us that we, parents and those affected, can contribute in helpful ways and even educate others. We are all on the same team. I completely agree. You know things that I don't know, my colleagues don't know, so tell us what you're experiencing. We need to know that. We need to have that documented for natural history. We need to recognize we are all on the same team, but we rely on you. You know more about the day-to-day happenings than we do, but we want to hear about them. And then finally, I love this T-shirt. Yes, we can. This is a New England Journal of Medicine editorial from 2011, talking about in rare disease conditions, patients have formed groups to drive research aimed at understanding and treating their particular illness. The key to success for such groups has been to support basic research that is held to the highest scientific standards, and this is what the RYR-1 Foundation is doing. So I think the future is very promising.